Dear Chairperson, dear ladies and gentlemen, first of all, I would like to thank the Scientific Committee for choosing our study as an oral presentation. The topic of our research is a retrospective review of our 6-year experience with shared motherhood treatment performed in lesbian same-sex couples. How does shared motherhood treatment works? In a classical synchronized cycle, the sharer undergoes ovarian stimulation and egg collection. Her eggs are fertilized with a donor sperm sample, and the recipient undergoes endometrial preparation and fresh embryo transfer. Shared motherhood combines the genetic and gestational parenthood so that both parents could be equally related to their future child. The possibility of choosing this treatment option enhances the reproductive autonomy of lesbian same-sex couples. Shared motherhood treatment is often a preferred option over donor IVF or donor insemination that involves only one member of the couple. In case of a medical indication, it also reduces the need for anonymous oocyte donors, or in some cases even surrogates. Since 2008, when amendments were made to the HFEA Act, in the UK it became acceptable within the regulatory context. Among other European countries, it is certainly practiced in Spain, allowed in Belgium and Netherlands, but in many other countries it is either not practiced or not allowed, such as France, Germany, and many others. Over the years, we have observed a rising demand for shared motherhood treatment among same-sex lesbian couples. However, there's a lack of large studies, and outcomes are still poorly understood. Our center in the UK was a pioneer in providing fertility care for lesbian same-sex couples. Since 1998, when the first case was accepted, we have performed over 10,000 donor insemination and donor IVF treatments. Currently, there are several terminologies for shared motherhood treatment. Although the intrapartner or intracouple egg donation precisely describes the underlying medical procedure, it feels too medicalized. The acronym ROPA was used by the Spanish group that first described its clinical experience back in 2010. However, this term might be less often used in the Anglo-Saxon medical literature. A US group coined the term co-IVF, emphasizing that the parties contribute equally to the entire IVF process. In contrast to donor or recipient, we prefer to use the term sharing and receiving partner to distinguish this treatment from the classical anonymous oocyte donation. Shared motherhood treatment can follow different treatment scenarios. In a classical, fresh, synchronized treatment cycle, the sharers and the recipient's menstrual cycles are synced with an oral contraceptive pill pretreatment. The sharer undergoes ovarian stimulation and egg collection, whereas the recipient undergoes endometrial preparation and fresh embryo transfer. The majority of cases in our series was like this. Another option is the frozen or non-synchronized treatment, when the sharer and the recipient's treatments are separated in time with the need of elective embryo freezing. There are also some less frequent but intriguing treatment options, such as during a synchronized cycle when the sharer and the recipient have both simultaneous fresh embryo transfer with the possibility of remaining pregnant at the same time. Understandably, this is a less frequent option because it puts a lot of physical and psychological strain on the couple. Same-sex couples also have the possibility of switching their roles, either for personal reason or for a medical ground, and both after a successful or unsuccessful treatment. And finally, if one patient already has previously created frozen surplus embryos from her own IVF treatment, she can donate it to her partner, which technically also qualifies as intracouple embryo or egg donation. Our retrospective study involved all consecutive 121 same-sex couples who underwent shared motherhood treatment during a 6-year period between 2011 and 2016. This flowchart represents the majority of couples who underwent the fresh synchronized option and the smaller proportion of patients who have chosen the frozen non-synchronized treatment, the respective number of fresh and subsequent frozen embryo transfers to calculate the cumulative success rate, the resulting live births, and the number of couples who still have unused surplus embryos. This table shows a comparison of baseline characteristics between the sharing and receiving partners. There was no difference in age or BMI. However, receiving partners were more parous and have undergone more previous successful or unsuccessful IUI and IVF treatments, suggesting that recipients were more active in pursuing a pregnancy or simply showing that they were the designated party to carry a pregnancy. For sharers, the slightly higher ovarian reserve markers indicate that in some cases, the medical indication for shared motherhood treatment was a diminished ovarian reserve in the recipient. In our series, most indications were non-medical, with the primary objective of achieving shared motherhood. There were also some genuine medical indications, such as previous failed fertility treatment, diminished ovarian reserve, or advanced maternal age. However, in many cases, medical and non-medical grounds were mixed. This table shows ovarian stimulation and laboratory characteristics. Most sharers were stimulated with a GnRH antagonist protocol and had GnRH agonist triggering. There were no moderate severe OHSS cases, although one sharer was briefly hospitalized after egg collection. The total number of performed embryo transfers, fresh and frozen ones, was 172, with a high proportion of blastocyst stage transfers and single embryo transfers, almost at 60%. The total cumulative live birth rate per couples started was 60%, and there was no difference in the cumulative success of the fresh synchronized and frozen non-synchronized treatment option. The twin delivery rate was at 14%. Basic obstetric outcomes was significantly better for singleton pregnancies. However, there were no severe prematurity in our series, and perinatal outcome was even favorable in twins. It is of note that the C-section rate at 41% was very high, even in singletons, which is well above the average rate in the UK, which is around 25%. In a subgroup analysis, we have compared the cumulative success rate according to the sharers or the recipient's age. For sharers, the outcome was not significantly different between age groups, with the oldest successful sharer being 40 years of age. As expected, there was no significant difference in outcome according to recipient age. In conclusion, shared motherhood is an acceptable, safe, and highly efficient treatment option. Most indications were non-medical, with several possible treatment scenarios. The cumulative success of the fresh synchronized and the frozen non-synchronized treatment option is similar, and sharing partners are eligible up until their late 30s. In terms of future research, the proportion of single embryo transfers could be further increased to reduce multiple pregnancies, and there is more data needed on obstetric outcomes. As to the non-medical aspects, more studies are needed to understand the background characteristics and motivations of prospective shared motherhood patients. And there's a lack of long-term follow-up to understand socio-psychological aspects of resulting new family structures. Thank you very much for your attention.
Thank you very much. We actually have our 5 minutes for discussion. So please, if people go to the microphone and identify themselves. And hello, our friend from Japan.
Sam Eshre from Japan. Can I ask you about the source of sperm? Is there how much proportion of the sperm donor as an unknown or known donor?
Yes, so practically, because these were female same-sex couples, so we have always used the donor sperm sample from a sperm bank, which in case of the UK was always, by definition, anonymous sperm donation, of course with the possibility of relieving or disclosing anonymity at the age of 18 for a future child.
So there's no known donors in this set of...
Also in the UK, well, there is a possibility in a small proportion of cases to use known sperm donors, but that's less frequent.
Thank you very much.
First, our ethicist, if I can see with the blinding lights on the right, and then you will be next.
Okay, I'm Hedy Mertens from Ghent University. I was just wondering if you have any data on the indications for the C-sections.
Yes, I mean, some of them were planned. There were also emergency C-sections, but this was not the main focus of our study, so that's why I've indicated that we need to have a more complete follow-up on this.
Okay, thank you.
Hi, this is Vladimir Silva from Portugal. Just a brief comment on your presentation. In Portugal, shared motherhood is also legal,
Okay.
Though only on private clinics.
Mm-hmm. Thank you very much.
One last very brief, well, we've got 3 minutes, so I'll take my time then. One question for me. A colleague of yours in the same clinic years ago presented, I think it was in Amsterdam, the rate of polycystic ovaries in same-sex couples, and I noticed that your AMH was so wonderful. I wish all my patients at UTLH had such a good AMH at 32. So, for long and short, you have what is your statistics about polycystic ovaries in your recipient couples?
Yes, so this was a relatively small sample, but in our clinic we treat a very high number of lesbian couples, either for donor insemination and IVF. So definitely the shared motherhood group might be different from those groups, for example, who would undergo IVF treatment. So as said, we have the baseline characteristics for these patients, but indications sometimes are quite mixed. So
the question was,
yes,
what is the proportion of PCOS in your group?
Mm-hmm. We did not look into it like precisely.
Okay,
but
well, I look forward to next time. Thank
sure.
you so much. I think it's a very interesting question because, yes. We have another minute and a half. Anybody else would like to ask a question?
They're just arriving.
Well, thank you.
Thank you very
It was really, really interesting and very well presented. We learned a lot. Thank you so much.